All right, so we got a really excellent presentation about a really quite prevalent disease, hypertension. So we're going to start with things a little bit rarer than that and work to things that are extremely rare. And these are some of my disclosures. So we're going to start with a story that we worked on now about 8 years ago, looking into personal genomes. And the story starts with the gentleman down here who's now one of the co-investigators, co-directors of the new biohub up in the city. And he had built a machine to sequence his own genome. And he founded a company around that, and then he came to our team and asked the question: I have my genome it was on a hard drive at the time. What do I do with this? And so, as our previous speaker mentioned, the most important risk factor that we needed to discuss was his family history, and so we took a proper pedigree and found that in addition to his father's history of sort of early coronary artery disease, aortic aneurysm, and ventricular tachycardia, he also had this cousin once removed who died suddenly at a young age. And so there was concern that he might be at risk for both common genetic disease impacting his cardiovascular health as well as his rare disease. And so you and Ashley and I worked with him to sort of look through his genome and say, you have a patient, comes to your clinic, has a genome in the hand, what do you do with it? And so so we started, of course, with a family history, and then worked with colleague Atul Butte and his team, who are now up in the city at UCSF, and using some of the GWAS data that was available at the time, tried to estimate what his individualized risk of common complex genetically driven disorders were. One of the challenges at that time was the data that was known was incomplete. So the variants that increased risk a lot were known, but the variants that decreased risk a little weren't yet known. And so as we learn not just about the top 20, but the next 300 genes that impact risk, many of these common disease risks come back towards the middle as you have larger cohorts, and you go from sort of the discovery GWAS to these large cohort-based GWAS, you get a more accurate estimate of risk. And so likely these are quite inflated risks for him versus actual. But the conceptualization was there, and you can see on the left for one trait, if you took the top 30 or so variants that were at the time associated with type 2 diabetes, you did have sort of a modulation of risk with some of them. So that was looking at common variation. I think that's still very much something that has not yet come to the clinic in most cases. But rare disease associated risk is something that we deal with every day in the clinic. And so we have patients and families who have family members who've died suddenly. We have patients and families who have cardiomyopathy, have heart muscle diseases, who have monogenic forms of hyperlipidemia that do significantly impact their risk. And so he came to us with a variant that was annotated by a publicly available tool as being highly associated with the risk of having hypertrophic cardiomyopathy. And so we looked into the data, and like many things, if you start with bad data, you're going to get bad answers. It turned out that that variant had been incorrectly published and annotated, and was actually in a gene where one exon could be flipped in either direction, and if read in the opposite direction would show a mutation, if read in the correct direction showed no mutation. And so we found that only through painstaking evaluation of sequences and reads and things like that. But we also looked for other genes that might have been associated with the cousin's death and didn't find any evidence of ARVC risk-related genes. And so we also did find rare variants in genes that were associated with common coronary artery disease risk. And so at the time, the certainty of those rare variants in causing any disease was not known, and it's still, in his case, unclear if this particular variant is associated with disease. There's not a lot of, it's not very frequent, and so with low frequency and limited phenotypic data, it's hard to know. In addition, we looked at both rare and common variants associated with pharmacogenetic profile, and so taking this together with the sort of risk assessment at the time, you could imagine a day where we can take rare variation, common variation, pharmacogenetic response, adverse effect variants, and variants that impact your choice of drugs, and come up with the ideal way to treat this individual. And I think we've heard some of the promise and mechanisms to get to that with our prior talk, so I won't belabor that. And so that's an example. And so working in the rare disease space, we have sort of a few examples that I wanted to go through to just show other mechanisms besides sort of big data genetics or long duration basic science, where we might be able to get to thinking about mechanism and drug therapy. And so the first is undilated cardiomyopathy, and so this is a patient I took care of a couple of years ago down at Stanford. So she's a 30-year-old woman with end-stage heart failure. She was brought in for consideration of transplantation. We talked to her about her family, and it turned out that she had very suspicious family history. Her father had died suddenly. Her uncle had died at the age of 45 after a long illness with heart failure. And her brother, who was a few years younger than her, had survived a sudden cardiac death a few years before. And so, of course, this looks like a pedigree of someone who may have a monogenic inherited disease. And so she met with one of our team of clinical genetic counselors and underwent panel-based genetic testing. At Stanford, this is all done through the genetic counselor and then sent to a CLIA-certified lab for interpretation. And our counselors also, as they're training others, are overreading and interpreting each variant they see. So in familial dilated cardiomyopathy, there's a challenge in that sometimes we don't have good ascertainment of family members because not everybody is getting echocardiography, and that's certainly appropriate, and that there are lots of, a laundry list of causes for heart failure and dilated cardiomyopathy, including the end effects of poorly treated hypertension in some people. And we know that from familial studies that if you have a highly penetrant variant, that you might find a causative gene mutation in about 20%, and then a significant modifier of disease that significantly increases the risk of disease in about another 30%. There's certainly variability in severity and onset. You have patients who have cardiomyopathy at birth or in early childhood, and then a large preponderance of variants lead to sort of adult onset dilation or gradual progression of dilation and cardiomyopathy. And so we're partnering with Ray Hirschberger, who's convinced the NIH to fund the precision medicine study. I think he called it that because he works at the Ohio State University. But we're recruiting now to really ask this question, is familial dilated cardiomyopathy and idiopathic dilated cardiomyopathy, do they both have a genetic underpinning a genetic risk? And so in the future, we'll have about 3,000 trios that have a biobank for metabolomics and exome sequencing and opportunities for additional discovery through and gene discovery through additional family members. We also have projects ongoing to help refine diagnosis. So as I mentioned before, there are many different potential etiologies of cardiomyopathy. One of the sort of long-standing debates in dilated cardiomyopathy is what the impact of this sort of entity known as viral cardiomyopathy or viral myocarditis is. There's quite good evidence but in small studies that development of autoantibodies to certain neoantigens may be contributing. You have a sort of insulting event, which is the bona fide viral infection, and then either through molecular mimicry or through actual damage of the heart muscle itself, you end up with a myocarditic response. And so we've developed a new platform to look at autoantibodies at very modest concentrations with modest cost to look across large cohorts of dilated cardiomyopathy and hypertension to see what may be underlying differential responses to hypertensive therapy as is reflected in the myocytes and in the structure of the heart and in the diastolic function of the heart. In addition, we've been involved in a clinical study looking at a novel therapy for a particular type of dilated cardiomyopathy. This is dilated cardiomyopathy due to mutations in the gene LMNA. This is a famous gene in part because Francis Collins has worked on it for many years, but also because it causes many different phenotypes depending on where it's mutated. And so I see patients who have mutations in this gene that cause dilated cardiomyopathy, but there are patients who have premature aging who have mutations in this gene who have progeria. There are also patients who have muscular dystrophy and mutations in this gene that have limb-girdle muscular dystrophy. And then there's a recently publicized case of a Canadian sprinter who is abnormally muscled, and she's female, and she looks like she's taking steroids, but she actually has a mutation in this gene which causes her to have a robust repair response in her skeletal muscle. And so, mutations in the same gene cause these very different phenotypes. In this case, we're talking about familial dilated cardiomyopathy, and a particular variant that causes this is engineered in a mouse model and showed a dysregulation of the p38 MAP kinase. There was a specific inhibitor of this that had been tested by Array Biopharma as a potential novel non-opioid analgesic. The trial for pain control was relatively neutral, but it was generally reasonably tolerated. When you gave this to mice that developed dilated cardiomyopathy, it showed that it abrogated this p38 phosphorylation successfully, and also abrogated the dilated cardiomyopathy they developed. And so this has now been taken into humans, and so Callum McRae and our group and a few others did this phase 2 study where we showed improvement in ejection fraction and exercise capacity and 6-minute walk distance. And so this is data that's submitted and hopefully will be coming out soon. And so this is, again, an opportunity from a rare disease to find a precision target and a precision therapy. So in hypertrophic cardiomyopathy, so these are patients who have abnormal wall thickness or increase in their heart wall thickness. This is an extreme example of a patient who has a septum. The left ventricular septum is here of nearly 5 centimeters. There's a spectrum of disease severity, and so one of the interests we have in the field is trying to understand, starting in rare disease, if there are things that may impact the degree of wall thickness that may be extended into more common genetic space. So we know that people with hypertrophic cardiomyopathy typically have variation in the proteins of the molecular motor or sarcomere, but there are genocopies, things that look like hypertrophic cardiomyopathy when you look at it phenotypically, but they're caused by a very different mechanism. And so it's important in a patient like this that we're making sure that they don't have one of these diseases, which has a very different and sometimes very malignant course, or in the case of Fabry's disease may have, or Pompe's disease may have a molecular therapy available now. So we know from a couple different studies that these phenocopies have increased mortality and risk. We also know that patients who have sort of bad luck and have 2 parents, both of whom gave them a sarcomeric variant, they may have increased risk of death, heart failure, or end-stage disease. So we, in this case, order a cardiomyopathy panel to make sure we're including genes that look for these storage cardiomyopathies. In this case, we find 2 variants in one of these sarcomeric genes. Neither of them had been seen before. And so these are, clinically, this is variants of uncertain significance, but from our perspective, these are very suspicious because this patient has such severe disease. And so some investigators at Stanford and elsewhere, and one of our colleagues who actually has a molecular lab in Bangalore, are working on modeling each of these variants that are found and showing if it changes the molecular motor. And I'll show you a little bit of their data in just a few slides. So we know sort of the top genes, but just like in the GWAS world, where with smaller studies we're powered for looking at the top genes, and very, very large studies we may be powered to look at a lot of additional genes. We know that if we look at individual families, we may be able to find additional genes that impact risk. And so we've done some discovery work looking at other genes and seeing if there are genes that are associated with rare forms of cardiomyopathy or patients who have hypertrophic cardiomyopathy in their family, but no evidence of genes and variants in the common genes. And so this is still work that's ongoing. We're also looking at ways that we can use our sort of the spectrum of disease we see to then look for genes and variants and pathways that may impact the severity of disease. So this is a small pilot study that is certainly underpowered for looking at anything common only through genetics. But when we add deep transcriptomics and multiple sources of additional evidence, we're able to prioritize genes that may be impactful for for the degree of hypertrophy we see. And then we use parallel data from animal models to look at whether these potential candidates may be dysregulated in both acute and chronic hypertrophy. And then we can go back to humans, and with tissue samples that we have from patients with hypertrophic cardiomyopathy, we can look in these tissue samples and say, is this gene upregulated in disease compared to normal? Is it differentially regulated among our samples? And we can look at genes such as this one that has been evaluated in one other paper as being associated with cardiac hypertrophy, and prove that abrogation of this gene in this case appears to be somewhat protective of the development of hypertrophy, but increases hyperplasia. And so we follow up genes like this for further study and trying to uncover what the mechanism of this finding is. So there is currently a novel therapeutic that's undergoing clinical trials that's really been informed by hypertrophic cardiomyopathy genetics. And so this is some work from our colleague Jim Spudich and his team, really looking at the fundamental kinetics of the molecular motor, in this case the myosin heavy chain head, and looking at the effect of monogenic disease variants on the kinetics and the force production by this individual gene. And at the bottom, we see that the mutant variant myosin head ends up creating an increase in intrinsic and ensemble force, and the thought is that this is the sort of fundamental underlying mechanism of hypertrophic cardiomyopathy. So we take this and then we use this assay, and one of the local Bay Area company licensed this assay to develop novel therapeutics. And so they developed this molecule shown in B, which is able to abrogate this change in force production, and subsequently have delivered it to cells and small animals and now large animals and humans, and show a similar effect shown here. And so this is a sort of first in-patient trial that I was involved with, where we have a patient who has hypertrophic cardiomyopathy with obstruction, where we see obstructive gradient shown here, about 30 millimeters of mercury, and over the course of 24 hours, we see this medication has abrogated that the obstructive gradient, in part by reducing contractility in the heart. And so we see about a 10% decrease in ejection fraction with this medication. And so this drug is now in phase 2 trials, and the phase 3 trial is being designed now. So that's sort of a few vignettes from the cardiomyopathy space. I want to take the rest of the time to show a vignette from the Center for Undiagnosed Diseases. So the Undiagnosed Disease Network in the US was born out of a program at the NIH clinical site in Bethesda. It was really spearheaded by these two people, Bill Gall and Cindy Tift, as a way to try to accelerate the science behind patients with very, very, very rare diseases, and hopefully also accelerate the diagnostic odyssey that many of these patients undertake. And so this started really in the dawn of sort of genomic sequencing, and so they started by using more classical genetics methods with LOD scores and microsatellite markers and things like that, and moved largely to exome and genome sequencing. but we're able to show that with a concerted effort, many of the challenges of working on a single patient or single family, single disease, and needing to sort of change your lab from one type of lab to another type of lab as things develop, working together, they're able to do this in many, many families. And so this was felt to be so successful that the NIH funded our current network, which involves 7 clinical sites, so 6 extramural and 1 intramural clinical site, 2 sequencing cores to do whole genome and whole exome sequencing, and model organism core, so you could rapidly go from a variant to a model system to see if you could sort of prove causality. And in addition to that, there's a metabolomics core and a biorepository to help with the future. So patients actually around the world can apply at this URL. They do need a referral letter from the treating physician saying that they have an undiagnosed condition, that the patient is willing to participate, and that the physician is willing to assume the care of the patient at the completion of their evaluation. We've developed the Stanford Center for Undiagnosed Diseases, modeled largely after the UDP site, and have now evaluated over 50 patients. And so this is one of our first patients, and is sort of an example of what we think can be done in a relatively rapid time frame. So about 15 months ago now, she was referred to our center. She's now 8 years old, but was born and within 24 hours had a very abnormal biochemistry, a very hypoglycemic and low pH and very high ammonia level. She had a sort of usual metabolic workup, which showed some mild abnormalities and has had subsequent episodes of decompensation that are treated with rather conservative measures. She's previously undergone testing looking for structural abnormalities. She did have some mild dilated cardiomyopathy, so that, of course, piqued my interest as a cardiomyopathologist. And she did undergo genetic testing initially with a mitochondrial nuclear gene panel, and then with whole exome sequencing, as well as, of course, a mitochondrial sequence, which did not show any suspicious variants. And so we got her exome data and embarked on reanalyzing that data. We started by looking at genes in the mitochondria. There's currently about 2,000 genes that are annotated as being involved in mitochondrial biogenesis, metabolism, et cetera. And we focused on the respiratory chain because the way she presented really fit with a respiratory chain disorder. When we did this reanalysis, we found one variant that was homozygous in one of the genes encoding for the last step in the respiratory chain, or complex 5. This gene had not been previously associated with disease, and when we modeled this variant on the structure of this protein, we did see that it changed the folding structure, or the predicted folding structure of the protein. We then had one of her samples from actually when she was about a month old that was saved in a freezer in the biochemistry lab, sent for this assay, which looks at the activities of each of those parts of the respiratory chain, and showed that indeed there is an abnormality in complex 5. We did cellular assays in our current lab, showing that there was this impairment of mitochondrial respiration. And we did multiomics profiling, both of RNA and metabolites from blood and urine, and showed that in this case the gene was not differentially regulated, but rather that her metabolomic profile was significantly abnormal, and this metabolic profile sort of matched someone who has a defect in oxidative phosphorylation, where the other components of mitochondrial metabolism are revved up in a compensatory manner. And we used pathway analysis to look at this in a different way and sort of came up with the same result. Because this is a novel gene, novel variant, we sent it to our colleagues at the Model Organism Core at Baylor, and they made a fly that knocked down this gene. They showed that no matter how you express this gene, if it was ubiquitously expressed, when you knocked it down, it was lethal. And when you added back the human wild-type gene, it rescued the flies, and they had apparently normal morphology. And if you added back the variant gene, you continued to have flies that didn't survive. And so this work is in preparation and will be coming out soon. So this is our teams. So the Center for Undiagnosed Disease and then the Undiagnosed Diseases Network sort of working together to take these single cases and try to get to a mechanism of disease and get to a genetic diagnosis. And these are the people who've worked on some of the other projects in the labs.